here at the University of Kentucky. I'd like to welcome everyone to today's webinar, Research in Progress webinar on the cost, quality, and value of public health services. And today we have an exciting topic on the effects of cross-jurisdictional resource sharing on the implementation, scope, and quality of public health services. And so to give everyone an idea of the flow for today's webinar, I'll first be introducing our presenters, who will then give their presentation. Then I'll move on to introducing our commentators, who will be giving their commentaries, and then we'll open the webinar to questions and discussions from the audience. So with that, it's my pleasure to introduce to you our presenters for today, starting with Dr. Justeen Hyde, who is Director of Research and Evaluation for the Institute for Community Health and an instructor at Harvard Medical School. Justeen is a cultural and medical anthropologist with a strong commitment to the use of participatory approaches to the development and implementation of health and public health research studies. Justeen co-directs the Massachusetts Practice-Based Research Network for Public Health, a group that has focused on the study of cross-jurisdictional service sharing as a strategy for improving the equity and quality of local public health services. Our other presenters, Dr. Debbie Humphries, who is a clinical instructor in epidemiology at the Yale School of Public Health and has a broad background in public health research and practice. Debbie has been a consultant in the areas of diet and physical activity, behavior change, sustainability, and community health programs, program monitoring and evaluation, and training and participatory monitoring and evaluation for organizations in Vietnam, Africa, and the United States. Debbie's research addresses interactions between nutrition and infectious disease, as well as programmatic approaches to improving public health. She has recently completed a pilot study investigating the effects of economic shocks on Connecticut local health departments. So with that, I'd like to turn it over to Justeen and Debbie.
Great. Thank you, CB. Thank you all for joining the conference call today, the webinar today. We are very excited to present, we think, preliminary findings, but this is the first presentation of our data that was funded under the Directive Initiative, and so we will be presenting some findings that are hot off the press from this study. I first want to introduce our research teams from both states, provide an overview of the study. Then we'll describe our sample, and we had an interesting sampling methodology, so I want to provide a high-level overview of that. And then we had a mixed method study, and we are still working on combining the qualitative and quantitative portions of our data, and at the moment they're running in parallel, so I'm going to provide a little snapshot of what we've learned from the qualitative data, and then turn it over to Debbie, who will talk about some of our findings from the retail food safety services and the comparison that we've done between single and multi-jurisdictional service sharing models. So we have had the pleasure of having a very nice large team working from both practice-based research networks in Connecticut and Massachusetts. On the screen you see all of the folks that have been working in Connecticut and Massachusetts, and then we've had a collaborating partner assisting us with the cost analysis, Adam Atherley from the Colorado PBRN. And so our team has been meeting monthly since we were funded almost 2 years ago. And to develop and implement the study, we've been meeting in person and by phone, alternating months. And it's been a really great experience for us to have this cross-state study. And I think the findings of our study are strengthened because we've looked at more than just one state. And so I would say that the idea of Connecticut and Massachusetts working together on a study has been one that we've been talking about since I think Connecticut joined the practice-based research networks. Both of us have relatively unique public health systems. They have home rule states. Both of them are very strong home rule states. And in both states, importantly, the responsibility for local health services falls on the municipality, meaning that every municipality is responsible for providing local public health services versus the county or state level in other states, most other states. For a long time, both practice-based research networks have been interested and focused on our shared concerns with the equitable delivery of local public health services, particularly in our smaller municipalities where resources are fewer, and sometimes geographic area is the distance from a larger municipal area is with more resources is pretty limited. So we have long-standing shared concerns with service delivery, and we in both states have a mix of public health service delivery models. We have single municipalities or independent health departments. We have partial, shared, and comprehensive shared service department, health departments, and then in Connecticut they have districts, which are separate entities that have come, where multiple municipalities have come together to provide services to multiple municipalities. So we have a mix of models in both states as well. So that's one of the reasons why we decided to go in and collaborate on this study together. There are lots of similarities. There are some differences between the states that we've been mindful of as we've developed this study. Massachusetts is a little bit bigger in population size. We have more municipalities, 351 versus 169 in Connecticut. And then we also, in Massachusetts, have more boards of health. We have 351 boards of health, and Connecticut has 74. An important difference between the two states for those more comprehensive shared service models or districts is that in Connecticut, the boards of health have given up local authority, and the authority is vested in the district, where in Massachusetts, the authority is retained for the most part by each municipality. So that's why we have a vast difference in local boards of health. And then in terms of the percentage of population covered by different types of health departments, in Massachusetts, the majority of our majority of our population is served by a municipal health department or board of health. And in Connecticut, only about a third of the population is served by a municipal board of health, and that's through a combination of full-time health departments and part-time health departments. And then conversely in Connecticut, 68% of the population is served by a district. This is just another characteristic of the municipalities in each state. The red bar is Massachusetts, the blue is Connecticut, and just to highlight that in Massachusetts we have a very large number of small municipalities under 10,000, and that is one of the big differences between the states. So our research question, I'm going to move us into our research question that we have stuck pretty close to as we've developed this study. It's really how do different organizational models impact the quality, breadth, and cost of local public health services. And here our intention was to compare municipalities that are working in a comprehensive way, either as a district in Connecticut or a comprehensive shared service model in Massachusetts. How does the cost, quality, and breadth of services vary in comparison to municipalities of similar size who are operating independently, so providing services as a single municipality? So that's been the focus of our study and driving our analysis at this point of the project. Our three service areas that we focused on, for those of you familiar with the directive project or not familiar with the directive project, there were some measures developed by a prior group of practice-based research network called Improved Measures. And so we selected 3 areas, 3 sets of measures in retail food safety, enteric diseases, and then obesity prevention as concrete areas that we could gather data on and compare the cost, quality, and breadth between multi-jurisdictional and single municipal health departments. So we adopted the improved measures in our study, and they have organized. We're focusing today on the retail food safety questions that Debbie will talk about. In terms of our methodology, we had a mixed method study. We pulled municipal characteristics from the census data. We gathered some state reported data, the retail food inspections in both states, the communicable disease data in Connecticut. That was tricky in Massachusetts. So we had to ask that in our surveys. It wasn't something we could gather from the state. And then our primary method was in-person semi-structured interviews that we conducted separately in Massachusetts and Connecticut. And these were largely interviews that were conducted over the phone. Some of them, when possible, were conducted in person. And we conducted those interviews with health directors or their designees. Our sampling was tricky and ended up being relatively tricky, I think trickier in Massachusetts than Connecticut because we have so many small municipalities. But what we really wanted to do was compare municipalities who were working in a comprehensive fashion, so in a district or in a comprehensive shared arrangement, compare the services that were provided in that group for Massachusetts and Connecticut to municipalities of similar population size who were providing services in an independent manner. So our stage 1 is to find those municipalities with comprehensive shared service models. In Massachusetts, we took all of them. There were only 10 of them, so we took all 10 of them. And in Connecticut, they were randomly selected. 8 districts were randomly selected. And then Debbie randomly selected municipalities with similar population sizes to those in shared service arrangements. And in Massachusetts, because we have so many really, really small, less than 1,000 people, we created 6 strata that we sampled by, and we also added a regional component because we know that our health departments in the western part of the state are differently resourced than those in the eastern part and in the middle. So we randomly selected a sample that created our sampling frame. We also selected some alternate municipalities in the case that we didn't get a response from any in our primary sample. Our response rate also varied by state. You can see that in Connecticut, their total response rate in Connecticut was 86%, and in Massachusetts, our total response rate was 49%. We had, in Massachusetts, a really challenging time connecting with our very small health departments. And I think it's a whole separate talk to talk about all the strategies that we use to try to connect with them. But if there's nobody there to answer the phone, there's just nobody there to answer the phone, which is the case, I think, in a lot of our municipalities. So, but you can see that in Connecticut, they had pretty high response rate across all the strata. And in Massachusetts, we did a little better in the 25,000 and over range. So our questionnaire, just a brief overview of our questionnaire. we had a combination of open-ended and closed-ended questions. We made the choice to record all of our interviews and have them transcribed because in prior studies we know that there's a lot of variation and nuance in the response to a structured closed-ended question. And so we really wanted to gain a good understanding of what that nuance was and how people were answering our questions. So we recorded all of them, had them transcribed. I'll talk about that, how we treated those data in a minute. But our questionnaire had a mix of questions focused on municipal characteristics, the governance of local health departments and boards of health, political influences, perceptions of political influences on funding and allocation of resources. It had a lot of information about the budgets and staffing, and then some specific questions focused on food safety, communicable disease with really enteric diseases, and obesity prevention efforts, community-wide obesity prevention efforts. And the screen in front of you just has some examples of questions that we asked of open-ended and closed-ended. The data that we've collected, all the quantitative data was entered into Excel and then transferred to Stata for analysis. All of the qualitative interviews, all the qualitative data was transcribed. We coded them all. And then we are in the process of looking through them, looking at variation and how questions are answered. We're actually using that to inform our quantitative analysis, highlighting where there are strengths, where there might be variations in the data. And then we're also conducting an independent analysis of some of the open-ended questions. Okay, so I'm going to launch into a few slides that just provide a sense of who actually participated in the survey. Sorry, I just lost my train of thought. In terms of the proportion of municipalities surveyed, we had in Massachusetts the majority of our municipalities that were surveyed were less than 10,000. And again, that is a function of who all is involved in service sharing agreements, and then we had to match that sample with independents. And so most of the municipalities involved in shared service arrangements in Massachusetts are smaller municipalities. In Connecticut, you can see that variation. There's slightly more in the 10,000 to 25,000 range and the 25 to 50,000 range. And very few in much larger health departments that are involved in shared service arrangements. So they made up a very small percentage of our sample. And so one of the things, just as a foreshadowing, one of the things that we think is valuable about this study is that it highlights some findings from small to mid-sized health departments and shows some economies of scale in that range, where we usually see studies that are focused on larger health departments because they're county or state. In terms of the demographics of the sample, in Connecticut, the poverty rate is a little bit higher in shared service arrangements or districts than non-shared, whereas in Massachusetts the poverty rate between the two is relatively similar. Massachusetts has higher poverty rate than Connecticut, be one highlight. Unemployment rate in both states is relatively comparable between shared and non-shared arrangements. And again, the unemployment rate in Massachusetts is a little bit higher. And then finally, we looked at population density, or the residents per square mile. In shared service arrangement, the population density is a little bit higher than in Connecticut versus non-shared. So that just gives you a little sense of who participated. I'm going to now just turn to some of our, this is one of the sets of questions that I think we were really interested in getting people's perceptions of the strengths and challenges of their service delivery models, depending on whether they were a single municipality or they were a multi-jurisdictional shared service, multi-jurisdictional. I really fumble with this word because they're different between the two states, but comprehensive shared or single municipalities. And so we pulled all of the qualitative data from the two states, and what you see in front of you are the strengths that people highlighted across both states. And so these were really sort of a shared perception of states. And the first two bullet points are related, I would say, in some fundamental ways, but people really highlighted their ability to be responsive to local needs, have a deep knowledge of their municipality. As one person says, we're a local health department, we're in touch with the municipality, meaning that we're in the same town, we're part of the same local government. People also highlighted the ability to be flexible and share services. They highlighted the interoperability across municipal departments that was possible in small towns, and then the freedom to not get bogged down in bureaucracy. So if, as a standalone, they were able to make decisions quickly and nimbly when they needed to. Some of the challenges, and these were major challenges, was lack of capacity to fulfill their responsibilities, which was often linked to limited budgets. And, as one woman in Massachusetts highlighted, that she was a one-man show, a one-woman show, I'll say. And she had to go out and do all the state mandates on her own, and it was really challenging to then go out and provide additional community health programs and services. People also highlighted the difficulty of hiring and retaining qualified staff, the challenges of political cycles and election cycles, and having to adapt to those every few years. And then just having a small number of staff responsible for providing a full range of services. In terms of multi-jurisdictional departments, by and large, the first 2 points here were very common across both states. The ability to hire qualified staff, which allowed them greater capacity to provide community health programs and services. So you can see in Connecticut, they are able to hire epidemiologists, communicable disease coordinators, administrative and finance team. So they talked about the strength as having depth of staffing and expertise, which allowed them to do other things like focus on upstream prevention and policies. A couple of in both states highlighted what we think of as having an entrepreneurial potential. They have some flexibility over their funding to try new programs, staffing patterns, and then nimbleness in staffing and consistency. I think in Massachusetts this came out a lot, that they were able to provide consistent services across multiple municipalities. The challenges, really, balancing good customer service with efficiencies in service delivery, especially in areas where the geographic spread was great. In those rural areas, it was hard to be present all the time when people needed them to be. Splitting time across municipalities challenged development of good working relationships. You had multiple people talking about having lots of different bosses, so not just one boss, but multiple bosses with different political differences. And then residents and political leaders often don't think or plan regionally, which is a challenge when that's the way that you're planning and thinking as a multi-jurisdictional health department. And so the final bit that I'm going to say, I mean, there were some differences between Connecticut and Massachusetts in terms of the qualitative data on these questions. In Connecticut, the smaller independent municipalities that we included in our sample tended to be wealthier than in Massachusetts. So there were a few more comments about being able to hire qualified staff. And then in Connecticut, districts and a few Massachusetts shared services, there were standalone, in Connecticut, there are standalone entities, which affects their day-to-day involvement in municipal decisions and some of the relationships across towns. So we're still looking at these data, but these are some highlights of what we found in terms of what people perceive to be the strengths and challenges of their service delivery models. And now I'm going to turn it over to Debbie, who's going to present some highlights from the food service data that we've looked at.
Great, thank you, Justine. One of the gifts of being able to watch all of this is I can also see some of the things that we've missed in our presentation. Specifically, the total number of interviews that we did isn't in any of those previous slides. In Connecticut, we interviewed 30 different jurisdictions. In Massachusetts, it was 39. So we have 69 participants total, which is both a large number and a small number, depending on how you look at it. In Connecticut, 8 of those were resource sharing, and in Massachusetts, 7 of them were. So we actually covered quite a number of different municipalities in this study. To go back to go into the food service costs, we asked a lot of questions about staff costs, indirect rates, overhead rates. Unfortunately, in the standalone municipalities, there really was no clear understanding of indirects or overhead. A lot of the costs of providing public health were actually folded into the municipality budgets. And so we had a lot of trouble getting some of these numbers. Now, our understanding is also that that staff costs are very often the primary driver of variation in costs, and so that's what we found. We were able to get costs out of all of the respondents, and that's the focus that we have, that's what we have ended up focusing on. In terms of what I'm presenting today is really just going to focus on the staff costs of food safety inspections. And first of all, note that there's no significant differences in the number of inspections per 1,000 population in either the shared or non-shared across Connecticut and Massachusetts. Part of that is our small sample size, again, the 69 municipalities. But also, in Connecticut, non-sharing jurisdictions do have a slightly higher proportion of the required inspections conducted. You'll see that in Connecticut, the non-sharing were doing about 94% of their required inspections, whereas the shared were only at 67%. And in Massachusetts, they were very similar. Sorry, that's what I was looking for. Okay, and we do notice that there's a very the scale is almost different in the proportion of inspections that result in violations in Massachusetts and Connecticut, and that's an area that we're going to need to look at further to really understand what's driving that, whether it's differences in the state contexts and guidelines for violations. So one of the ways that we looked at calculating the food safety costs is we actually asked each respondent to tell us about all of the people, all of the employees, all of the contractors, everyone that they were paying, every human being they were paying to do something related to food safety. And then this slide actually shows we took the time each week, the number of hours each week that each of these staff positions was contributing to food safety. And then we divided that by the total number of hours spent per week on food safety to get a proportion of the food safety staff time that was being contributed by each of these different kinds of positions. So the health director, note that in standalone the health directors are the median, the solid line in the middle is above 0. And so basically you'll see that the health directors are doing more of the food safety inspections in the standalone. In the resource sharing, the sanitarian and environmental inspectors, again, there seem to be more of them doing the inspections than there are in the standalone, which in some ways speaks to the observations that Justeen shared earlier about the ability to hire more specialized and trained staff in the resource sharing municipalities. In terms of the cost estimates, so this is the total number of inspections, which is the total FSI, total number of food safety inspections, and the number of inspections for resource sharing and standalone departments is significantly different in both Connecticut and Massachusetts. Interestingly, in Connecticut, the standalone are doing more. In Massachusetts, the resource sharing are doing more. However, the cost per food safety inspection, and these are unadjusted costs, is not significantly different for resource sharing and standalone departments. Estimated cost was $176 per food safety inspection for standalone versus $137. And again, these numbers, the challenge is also, again, our limited sample size, that the resource sharing is 8 in Connecticut and 7 in Massachusetts. In doing some initial modeling of predictors of the total food safety inspection staff cost, one of the reasons that Justeen shared both the unemployment and the population density data early on is that those were some of the factors that we were looking at in potentially the contextual factors that might influence food safety inspection staff costs. That as unemployment goes up, you might expect lower staff costs, and we do see, the p-value is 0.01, but you do see some effect of unemployment. Population density, also here we were expecting that a higher population density might mean less driving time and a more greater efficiencies in being able to conduct the food safety inspections with less travel time. Note that we did find a highly significant nonlinear effect of the total number of food safety inspections. So we included the quadratic term in the model and found that to be significant. And one of the challenges in all of this analysis is that because we were looking to the same size municipalities, we're working with overall both standalone and resource sharing departments that are not doing all that many inspections. And so when we calculate the minimum, where the minimum cost per inspection would be using this analysis, it would be at almost 2,000 inspections. And we only had one resource sharing department in Massachusetts and one in Connecticut that actually reached that number. So the economies of scale that the analysis suggests would require more municipalities to get together than we actually see in our sample. The initial conclusions of this cost analysis are really that the primary driver of inspection staffing costs is the total number of inspections being conducted, that there is a nonlinear relationship between the cost per inspection and the number of inspections, but again, it's reached above the maximum number of inspections conducted by all but one of the jurisdictions sampled. Service sharing status is not significant other than as a contributor to total number of inspections. Some of the key contributions that we think this work makes that Justeen alluded to is that really we're looking at small and mid-sized jurisdictions that are often hard to study, and so we think we're making a strong contribution to looking at that size of jurisdictions. The mixed methods lets us get insights into quality and the complexity of the measures, and really looking at some of the costs of local public health services. Some of the next steps, lots of analysis remains to be done. The quality indicators that we've collected really need to be factored into the cost analyses to put those together for the food inspections. The mixed methods analyses to look more closely at the political influences on public health services. And then we also want to see what analysis we can do on the variation in delivery and cost of enteric disease and obesity prevention services. And that concludes the overall presentation. And this is where you can get the background on the PHSSR website. And then I believe I turn it back to CB.
Thank you, Debbie. Thank you, Justeen. And so before I introduce our commentators, I'd just like to remind everyone, if you have any questions about the presentation, please feel free to type them in the chat box. If we don't have any more time at the end of the webinar, we'll always make sure to forward those questions to our presenters, and they can address them directly to you guys too as well. So our we have three commentators today, but I'll introduce our first two. We have Patrick Libbey, who is co-director of the Center for Sharing Public Health Services and a clinical instructor in the Department of Health Services, University of Washington School of Public Health. The Center for Sharing Public Health Services has grown to be a national resource and cross-jurisdictional service sharing for local health departments. Pat has a wealth of experience working in public health at the local, regional, and national levels, which includes serving as Executive Director of the National Association of County and City Health Officials and a local public health director. Pat has also served as a founder and incorporating board member of the Public Health Accreditation Board. Our other commentator is Jennifer Kertanis, who is director of the Farmington Valley Health District in Connecticut, where she oversees the delivery of public health services for 10 municipalities. In addition to being a lead for the Public Health Practice-Based Research Network, Jennifer is also a former executive director of the Connecticut Association of Health Departments. She has previously worked for 11 years with the Connecticut Department of Public Health in the Environmental Epidemiology Unit, working with communities to assess the health implications of hazardous waste sites and establish the asthma surveillance program. So with that, I turn it over to you, Pat and Jennifer.
Great, thank you. Are you able to hear me?
Yes, loud and clear. Go ahead, Pat.
Okay, thanks. I wasn't sure if I'd drop. Thank you for the opportunity to comment, and thank you in particular to Dr. Hyde and Dr. Humphries and their colleagues for this research. As was mentioned, the Center for Sharing Public Health Services is a Robert Wood Johnson Foundation national initiative housed at the Kansas Health Institute with the purpose of exploring, informing, tracking, disseminating, learning about shared approaches to delivering public health services. We've been in business, if you will, since May of 2012, and we've really come to understand cross-jurisdictional sharing as the deliberate exercise of public authority to enable collaboration across jurisdictional boundaries to deliver public health services. What we've also seen from our work and from other sources is that cross-jurisdictional sharing has been shown to have positive results in improving both effectiveness and efficiency in delivering public health and other public health services. However, most of the evaluation work to date has been case-specific, often in the form of case studies, and oftentimes self-reported. So for the most part, it has not been uniform or standard measurement across efforts. And so this piece of work, we think, is a significant addition to our understanding of the evaluation of cross-jurisdictional sharing. Three things in particular I would note from today's presentation. First is that there was really only one means of cross-jurisdictional sharing examined, and that was what we would refer to as regionalization, in this case the comprehensive or district models. And broadly, there are other categories of sharing differently: customary agreements, mutual aid, those sorts of things, service-related arrangements between jurisdictions, and even shared functions with joint oversight. And I raise that only to note that you may have different results associated with different sharing models. That said, though, the perceptions of strength in the delivery models that were presented very closely match much of what we have learned from our demonstration sites, the case studies that we've commissioned, some of the survey work done by the International City-County Management Association and the like. But just a caution that we're looking at one model in this. It doesn't necessarily speak to all ways in which services might be shared. The second point or question I would raise, the cost model, and I understand in part why, the cost model excluded overhead and indirect costs and used direct staff only. And our experience and observation, and in a number of our case studies and survey work, it does indicate that there's often an economy of scale realized in the overhead and indirect that can result in a lower total cost, lower unit cost, and or it can be used in some ways to enhance service quality. It's difficult when the information regarding those costs is not readily available, or is in some ways the cost is real, but it's buried and not retrievable oftentimes, particularly when it's incorporated in the jurisdiction's overall budget. But they are still costs. We also saw that the issue of overhead was a motivator in a number of cases where smaller jurisdictions did consolidate or merge. The third issue I would raise, and it's more one going forward, and it deals with the qualitative and the open-ended questions going forward. These were informed exclusively by the health officials or their designees in the jurisdictions. And we have found that the response to those questions can and does vary significantly when the respondent is a different critical player. These could be policymakers, often elected officials that actually have the authority to enter into shared arrangements, and also different again when we talk with general government general government administration, city managers, county administrators, and the like. Their perspectives on the value of cross-jurisdictional sharing and the value of the particular model they're using may vary, and certainly what they want out of a relationship oftentimes varies. Not necessarily mutually exclusive, but different. In that lens, I think, need to be aware in a strategic and a tactical sense that those considerations are also very important in incorporating any kind of an approach to a cross-jurisdictional relationship. So again, I want to thank the research team for this work. It's definitely an important addition to the background information, the material that we have, and look forward to the continuing refinement of this work and its expansion into other areas. So, thank you.
Thank you, Pat. Jennifer, I turn it over to you.
Great, thank you. Good afternoon, everyone. It's my pleasure to present the practice commentary today on behalf of our team, and I'm particularly honored to be a commentator aside Pat Libbey, who has been a mentor, colleague, and friend of mine for a very long time. It's great to hear your voice, Pat. I'd like to thank our research partners and advisors led by Justeen and Debbie. This has really been an exciting research project, and they have been really instrumental in advancing this work for the states of Connecticut and Massachusetts and the broader practice-based research network. And I'd also like to acknowledge my practice colleagues in Mass and Connecticut for their participation and guidance throughout this research study. Regionalization and service sharing of local public health services is certainly growing in interest as we continue to explore the most effective and efficient ways to deliver the diverse array of services provided through local public health with increasingly limited resources. And states like Connecticut and Mass, with decentralized local health departments and many small independent departments, are really prime areas of investigation regarding the political, economic, and programmatic benefits and challenges associated with service sharing and regionalization. In the absence of specific data on cost, benefit, and improved effectiveness of service sharing or regionalization, I've found that most decisions regarding mergers or sharing are often informed more by perceptions of these different structures. And it certainly was interesting to me to see that in many cases the perceptions of strengths cited for both the single municipal department and the district or shared service arrangements were driving towards a similar goal. For instance, both models strive to be responsive to local needs. The standalone departments indicated that knowledge of the municipality, flexibility, and ability to share services helped achieve that responsiveness, and multi-jurisdiction departments cited increased capacity to offer a wide array of services and flexibility with respect to funding and staffing as characteristics that allowed them to meet local needs. While standalone departments most often cited lack of resources, both financial and staffing, as the most significant challenge, multi-jurisdictional departments often reported that towns, leaders, and residents did not think regionally. As greater consideration is given to service sharing and regionalization, this seems to be a challenge that could be overcome with additional education and outreach. Regional practice and resource sharing of public health requires systemic change from within all the participating organizations to commit to fairly and equally supporting all the organizations politically, economically, and programmatically. So I think that's a challenge that we can overcome. In my experience, for better or worse, economics and cost benefit are more heavily weighted by political leaders and those making decisions regarding regional sharing or regionalization. And cost effectiveness certainly is a challenging area of research, and it is inextricably linked to quality and standardization. For this study, we purposefully selected food service inspections because it was done by all local health departments in Connecticut and Massachusetts, and we could readily access some quantitative as well as a qualitative component. Even picking this more standard service, we were challenged by variation in potential quality of food service program, the credentials of those who perform inspections, the type of follow-up performed as part of achieving compliance, and workforce development are potential variables that can impact the cost and economic implications of different delivery models. While previous studies have indicated that the primary cost driver in food inspection is staffing, there is a need to explore more fully the more elusive quality measures. As a local health director, I personally believe that one of the most significant attributes of a quality local health department is one that has the expertise and staffing to allow for flexibility and responsiveness to the ever-changing public health challenges we face. The multi-jurisdictional departments were far more likely to report diversity of staffing and expertise, while single municipal departments were more likely to report being one-man shows having to do all of the state-mandated services. I feel that this is clearly an area requiring additional exploration, and I think that accreditation and the foundational capabilities are providing a solid framework for exploring this in more detail. Lastly, while we continue to find creative and meaningful ways to illuminate the value and importance of disease prevention and health promotion, we must also continue to explore ways in which we can make the connection between different levels and structures of local public health systems and health outcomes. I think without that, as challenging as that is, we will be more challenged to convince policymakers of the need to invest in good public health services offered in the most effective, efficient, and highest quality ways. With that, I will conclude, and if Sam Wong is on the phone and would like to make any additional comments from a practice standpoint, I think that was the opportunity we wanted to provide. And if he's not, we'll turn it over to CB for question and answer.
Thank you, Jennifer. Thank you, Patrick. I just wanted to check. Sam, are you called in? Do you have audio controls? If not, I'd like to turn it back first to Justeen and Debbie to respond to the comments. You might be on mute. You might have to unmute your phones.
Pat, I really appreciate, this is Debbie, I really appreciate the thoughtfulness, and you're highlighting some of the challenges that we faced in trying to make a decision in the study design even about the one model of sharing. And we're very aware of that spectrum of sharing models, but in needing to compare apples and apples, we chose to focus on only the one. We do have in our data additional information about less formal, so some of the collaborative emergency response sharing and so on. But we agree that that's a very interesting area for further work. And we also agree about the limitations of the staffing. And we tried to ask about indirects to get at that. And we're very clear that not being able to pull the costs, the full costs of food safety inspections, for example, out of the municipal budgets is a limitation. Justeen, do you want to say anything else?
No, I would agree entirely. And I guess the only other comment that I'll make is that in Massachusetts, one of the things that we have struggled with historically, and I think in this study, is that we know that the health departments that we tried dozens of times to reach out to in many different ways probably are the ones with the least capacity, those independent or single municipality jurisdictions. And we really wanted to include, gather a picture of what service delivery looked like in those municipalities, and it was really challenging. And I feel like that has, I think we want to go forward cautiously in terms of, for those single municipalities that did participate, and question whether or not they have more resources or greater capacity by virtue of being able to participate. So that was one comment that, as Pat was speaking, that came to mind. But I appreciate both of you taking the time to comment and provide your different perspectives. I know that Pat Chaco is asked a question. CB, do you want me to just read it? I'm not sure if everybody.
Sure. So Pat asked about whether or not you considered how local health departments in Connecticut, if there's the unionization of the local health departments. She commented about how, I guess, 89% of full-time municipalities are unionized, while about a third of the part-time municipalities are unionized. So is it something that you may have considered in your cost model to include, particularly for the Connecticut cost equation?
We actually didn't include that, and that's a very good point. She also highlights the role of the unionization in terms of even the capacity to make the district, to make the decision to be a part of a district as a, sort of an external influence, and the questions of why municipalities choose to be part of a district or not is actually something that we are trying to look at as we move forward with the costing model, to really know that we don't have all of the reasons why a particular municipality is choosing to participate, and that unionization may be a key piece. So thank you, Pat.
I guess we have a minute or two more for additional questions from the audience. Again, if you're not able to put it in, you can always get in touch with Debbie and Justine directly. I guess we could wrap it up by just asking you sort of what are the next steps moving forward in terms of have you been able to share some of these preliminary results with the local health departments that participated, sort of the gain of, sort of to obtain feedback, especially when it comes to trying to maybe later on in the future try to estimate these indirect costs and so on. Yeah, and I guess other dissemination plans too as well.
I'd say
so
that's on our June agenda.
Right. And I would also say that we finished collecting this data in April. So this is literally hot off the presses. And we will absolutely get it back to the local, to both the Connecticut and Massachusetts associations of departments of health. And in addition, we will be doing a presentation at APHA in the fall.
Back
All right.
Back in October, we held a joint webinar between the two states, highlighting some prior research findings from both of our PBRNs, and we have talked about doing that again. So that will likely be on our agenda. And then local conferences, like we have our local Mass Health Officer Association conference, and in Connecticut they have local public health association conferences where we had talked about getting the information out that way as well.
That's great. Thank you so much, Justine and Debbie, for sharing these hot off the press results. And we'd like to thank again our presenters and also our commentators for Pat and Jennifer for sharing your commentaries too as well. Again, this presentation will be available for download from the S4A website, and if you've missed our past webinars too as well, those are also available for download too as well. And so we'd like to invite everyone too as well to also view our upcoming webinars, and we hope to see you there too as well. And with that, thank you again to our presenters and commentators, and for everyone for joining us for today's webinar. And we hope you have a great day. Thank you so much, and hope to see you soon. Bye-bye.
Thank you.
Bye-bye.